My name is Landon Brown. I'm a fellow at the Duke Cancer Institute in Durham, North Carolina. So the study that I'll be presenting is a single-arm phase 2 study looking at the efficacy of avelumab in patients with neuroendocrine or aggressive variant prostate cancer. And we know these patients with neuroendocrine or aggressive variant prostate cancer have poor outcomes with hormonal therapy and chemotherapy. So we're looking at the efficacy of checkpoint inhibition in this population. Our study had two inclusion criteria. Patients either had to have neuroendocrine histology or having adenocarcinoma with one of three aggressive variant criteria, being liver metastasis, bulky radiographic progression, or a high serum LDH. Our primary endpoint was overall response rate, with secondary endpoints being progression-free survival, overall survival, PSA response, and safety. We ultimately enrolled 15 patients on this study. It was a heavily pretreated cohort with a median of 2 prior non-ADT therapies and 70% of patients having received prior chemotherapy. The top-line result was that out of the 15 patients enrolled, only one patient, or 7%, had an overall response. That patient had a complete response, and that one patient also was the only patient to have a greater than 50% confirmed PSA response. The progression-free survival median was 1.8 months, so a very short PFS, and overall survival median of 7.4 months. So ultimately, the top-line results from this study are that avelumab appears to have limited clinical efficacy, with only 1 out of 15 patients responding. And this patient did have microsatellite instability high prostate cancer, indicating a good reason for why they did have a response to checkpoint inhibition. The study was stopped early after 15 patients due to futility due to this low response rate, unfortunately. Sure, so for our inclusion criteria, we wanted to include two groups. One was the patients who have neuroendocrine histology on their biopsy, or patients who may not have neuroendocrine histology, but have certain high-risk clinical criteria, such as liver metastasis, bulky radiographic progression with a low PSA, or having a high serum LDH. So a patient had to meet one of those two criteria. They could be treated with prior hormonal or chemotherapy, but not checkpoint inhibitor therapy. And we did not use serum markers as part of the inclusion criteria, like chromogranin or neuron-specific enolase. Patients who had biomarkers such as CEA or chromogranin that were elevated at enrollment, those were trended moving forward. Very few patients on this study had those serum biomarkers, and so those results are not presented, and no patients had any responses. But if they did have a high biomarker, that was followed moving forward, but it was not specifically part of the inclusion criteria for these patients. At this time, we don't have any information on the PD-L1 status of these patients. We know that PD-L1 expression is fairly uncommon in prostate cancer, and it was not part of the initial inclusion criteria or stratification for this study. We do have tissue available on these patients, and so it may be part of some future studies to look at what the PD-L1 expression is in this study, but we did not use this as an initial either inclusion criteria or part of the stratification in this study. That's a good question. We have, on these patients, there are banked plasma samples that we are planning on assessing for cell-free DNA for future correlative science. We don't have those results just yet. And as far as circulating tumor cells, we did not collect circulating tumor cells in this study, but in future studies are planning on including circulating tumor cells for assessing for genomic or phenotypic characteristics of those circulating tumor cells for biomarkers of response to therapy. But on this study, we did not collect circulating tumor cells, and we're planning on performing cell-free DNA analysis on collected plasma samples. In terms of some of the studies that we're planning related to this study, we are planning on doing some correlative work looking at, as I mentioned before, cell-free DNA on plasma samples that are collected. And in addition to this, we have banked peripheral blood mononuclear cells, or PBMCs, and we're planning on assessing the immune cell subsets, particularly focused on immunosuppressive cell subsets, and looking at how these immune cell subsets or the immunophenotype changes over time in these patients treated with a checkpoint inhibitor, as well as comparing the immunophenotype of patients with neuroendocrine prostate cancer with other cohorts of patients who may have more traditional prostate adenocarcinoma. So looking at the immunophenotype of these patients. In terms of next clinical studies, we saw in this study that avelumab had limited efficacy and many patients had rapid early progression. So we're looking at a strategy similar to what's used in small cell lung cancer or other diseases, combining chemotherapy with immunotherapy. So using a chemotherapy upfront in neuroendocrine prostate cancer that is platinum-based for the initial response, and then treating them with checkpoint inhibitors as a maintenance therapy or continuous as a maintenance therapy to prolong that response. And one area that we're particularly interested in is dual checkpoint inhibition, because we know in prostate cancer there is some evidence that the addition of anti-CTLA-4 therapy can increase the response rate. So we're interested in looking at combination of chemotherapy with platinum chemotherapy with dual checkpoint inhibition and seeing if that approach can induce more responses and help prolong these responses to help men with neuroendocrine or aggressive variant prostate cancer live longer and ideally live better.